Good evening, everyone. This is Lene Hartwig from Colorado Urology, and we're here this evening with Dr. Saram. Dr. Saram is fellowship trained in urology. He's been in urology for about 18 years, and his specialties include BPH, or Enlarged Prostate, UroLift Center of Excellence. He is a UroLift Center of Excellence provider in robotics surgery, laparoscopic and robotic kidney surgery, also kidney stones, robotic prostatectomy, and urinary incontinence. So Dr. Saram, I'd like you to take it away.
Great, thank you. Thanks, Lene. And many thanks to everybody who's joined us this evening. But what hasn't changed is the fact that men still suffer from medical issues, and specifically issues related to the prostate. And we continue to see people who have difficulties with their urination or have concerns about the health of their prostate and bladder, and they want to come and see us. And so we're happy to do this seminar. We're happy to answer any questions you may have. And of course, we're available to see you either virtually or in person if you have questions about what's going on. Here we are. We're going to talk about the importance of your prostate. You hear the term BPH often, and the question always is, well, what exactly is BPH? So we're going to talk about that a little bit. What do we do to try to diagnose it? What do we do when men have difficulty with their urination related to their prostate? And then we're going to focus on an area that is an area of my expertise. It is a very exciting time when it comes to treatment of prostate conditions, and UroLift certainly has a earned space within this disease. And so we're going to talk about that a little bit as well. The prostate gland is normally about a walnut-sized gland that sits at the base of the male bladder. It surrounds the urethra, and in reality, the prostate really is a sexual organ. It produces and transports semen, is important in men during the childbearing years. Once men are done having children, the prostate really does not have a function other than to produce semen. Unfortunately, by virtue of where it sits and by the fact that the prostate tends to enlarge as we get older, it tends to pinch off the stream of urine because it's surrounds the urethra, and that's where the pathophysiology or the disease of BPH happens. The prostate grows as men grow older. There's kind of two phases of growth. At first, when men are born, into their teenage years, there's a fairly rapid growth in the size of the prostate. And then the prostate size remains relatively stable and dormant until men enter their 50s and beyond. And it's then that the urinary symptoms usually begin to become more bothersome. There are a lot of different conditions, and I think it's really important for people to understand that one does not necessarily mean the other. Prostate can do a lot of different things when it comes to its disease states. And so prostatitis is a term that you may hear. Anything itis in medicine means inflammation or infection. So prostatitis is a swelling or inflammation of the prostate. Oftentimes is a result of an infection. Sometimes it is a non-infectious prostatitis. But prostatitis usually is a temporary condition. So you have it, you're given some antibiotics or whatever treatment for prostatitis, and after the course of treatment, the condition usually gets better and people go back to their normal life. In men who have prostatitis, oftentimes develop urinary difficulties, somewhat sudden onset. It sort of comes out of nowhere, and they have a hard time peeing. They have burning, pain, discomfort, slow stream, a lot of the symptoms that are pretty similar to BPH, but the onset is usually quite sudden. And if it's infectious, it's usually associated with a fever or pain that you don't normally have with prostate cancer or an enlarged prostate. So you may hear the term prostatitis if you go to see your doctor with acute changes in urinary symptoms. Another thing that the prostate does as we get older is that it can become cancerous. And so, of course, when men develop urinary difficulties, one of the main reasons why they go to see their doctor is because they're concerned about prostate cancer. And it's actually pretty important for you as a patient, if you go to see your doctor and you talk to them about your urinary difficulties, it's important for you to say up front, doc, really, my concern is I just want to make sure I don't have cancer, if that's your concern. Or doc, I know I don't have cancer because I've been tested for it, but my symptoms are getting really bothersome, and therefore we need to focus on that. And so as physicians, I think it's really important for us to understand and appreciate the patient's primary concern and why they're there. And oftentimes it's to make sure that the prostate is not cancerous. Of course, prostate cancer is a whole different ball of wax. It's a whole different disease state. Hopefully someday we're going to have a seminar where I can talk to you guys about prostate cancer. But as part of the workup for urinary difficulties, we often test you and make sure that there's no major concerns about presence of prostate cancer before we focus on other things. Now, lastly, and the reason we're here tonight, is the prostate can become enlarged. And as I said in the previous slide, enlargement of the prostate gland can result in urinary difficulties. These conditions sometimes can coexist. You can have all of them at the same time, and sometimes you can have one or the other. But one does not necessarily mean you have the other. Now, as we get older, men develop prostate conditions, the prostate symptoms. And so if you ask a 50-year-old man, he's probably got about a 40% chance that they're going to have some BPH symptoms or urinary symptoms, and we're going to talk about what BPH really means. As we get into our 60s and 70s, the number goes up significantly, so that by the age of 70 or 80, something like 80 or 90% of men actually have urinary difficulties. That doesn't mean that that's all an emergency, but certainly urinary difficulties that can affect their quality of life. And so it's really important for us to appreciate that, and it's also important for us to not assume that that's something that just happens with aging. I see that a lot when people come to see me and we ask them about their urination. They're really suffering and it's affecting their quality of life, yet they sort of assume that just because I'm getting old, it's okay for this to happen. Well, it's not, and certainly there's lots of options available to try to improve the quality of life and also improve the health of our patients. So what's BPH? BPH stands for benign prostatic hyperplasia. Benign, meaning that it's not cancerous. Hyperplasia, meaning that it's enlargement or growth of the prostate. And so to get the diagnosis of BPH, we have to always make sure that there's no cancer. And we usually do the testing prior to giving you the diagnosis of BPH. One thing that's really important to remember is everybody knows about the blood test PSA. PSA stands for prostate specific antigen. PSA is a antigen, is a protein that all men's prostates make. And so all our lives, we make PSA. PSA is released into the bloodstream, and so it's measurable. As the prostate gets bigger, we tend to make more PSA. Also, prostate cancer can cause a rise in the PSA. The PSA by itself is not specific to indicate that somebody has cancer or somebody has BPH. There's a lot of reasons why PSA goes up, but PSA is part of the testing that we do when we're trying to evaluate men for BPH. What ends up happening is if I always tell my patients, think of your urinary system as a pump and a valve. The bladder is the pump. The bladder is what pushes the urine out. The prostate is the valve that surrounds the urethra. And if there is an abnormality in the function of the bladder or the function of the prostate, men develop urinary difficulties. So as we get older, our prostates tend to enlarge and they tend to become tighter. And as it gets tighter, the flow of urine goes down and the bladder has to work extra hard to try to push the urine through this obstruction. And that's where BPH happens, and that's how BPH happens. So what happens when we have BPH? Normally a bladder is a muscle. When it has to work extra hard to push the urine through the obstructive prostate, the muscle can become thickened and eventually it can stop working. So the analogy that we use oftentimes, it's similar to the heart and high blood pressure. So the heart is a muscle that pushes blood through the bloodstream, through the veins and arteries. If there is high blood pressure, that means the arteries are tight, and therefore the heart has to push even harder to try to push the urine, try to push blood through those arteries. And so over time, the heart can become damaged and it becomes dilated or stretched out and eventually quits working. Same exact thing can happen with the bladder. If the muscle of the bladder has to work hard over many years, eventually it can become hypertrophied or become thickened, and eventually the muscle can quit working, and therefore people start to retain urine and are not able to urinate properly. And this over time, and it's not immediate, but over time it can result in permanent bladder damage. And that's where we are most interested is to make sure that people's bladders remain healthy throughout their lives. What you see here on the top is a depiction of the prostate in relationship to the bladder, and you see the urethra sort of going through the prostate. And down here are pictures, cystoscopic pictures, so we're looking inside the prostate with a camera. And normally, in a child, the prostate is open, and there's an open road into the bladder. The black in the back is actually inside of the bladder. As men become a little bit older, the prostate tends to enlarge, and so these lobes of the prostate start to fall in, and they obstruct the flow of urine, and so you can't look inside the bladder like you can in a younger person. When a person becomes even older and develops more enlargement of the prostate, the lobes really fall in. We call this kissing lobes. So basically, these are the two lobes of the prostate, right side and left side. And when they become enlarged, they fall in on each other. And so your bladder has to push the urine through this area. As you can imagine, it has to work pretty hard to push the urine through. And that's what happens when people develop BPH. And so what happens? You end up having frequent urination because the bladder, again, it's a muscle. And so when it has to work extra hard and work extra hard over a long period of time, it becomes irritated and it starts to develop frequency of urination. Multiple trips to the bathroom. Urgency is a big problem. Men say that suddenly they get the urge and they can't stop it, so they may have a little bit of dribbling. When they urinate, they have a difficult time getting the stream started or to have a sustained stream, and so it's an interrupted or slow stream. And so they feel that they're not completely emptying their bladder. And of course, that results in multiple trips to the bathroom. And what ends up happening is people end up suffering a reduction in their quality of life. And so, again, most men, being men, we tend to minimize our medical issues, and we tend to sort of not take it seriously because we're afraid of, the workup or the testing or whatever else may happen. But the reality is that men who have BPH truly suffer, and they end up having a worse quality of life. And so people avoid traveling, they have interruption of leisure activities, they use the bathroom stalls instead of urinals because they're embarrassed about their flow or don't want to hold people up, and they have disruption in sleep patterns, which of course becomes a really big deal as we get older because getting up at night to urinate is fraught with risks, risk of falling, risk of not getting enough sleep, which of course leads to problems during the daytime. And so there's lots and lots of problems that can result as a result of a improperly treated BPH problem. So how is it diagnosed? So medical history is very important. When patients come in, we ask them questions. We say, all the questions about the urinary symptoms that we just talked about, all those symptoms. We ask questions. We do a physical examination. We do a rectal exam to check the prostate. Now, men usually don't like that test, but it's an important test because what we can do with that is to sort of approximate the size of the prostate, although a rectal exam or a digital exam really is a very poor way of measuring the size of the prostate. But we also, more importantly, are interested in texture and the character of the prostate because that's one of the ways that we screen for prostate cancer. So if we do an exam and somebody has a mass or a nodule or a firmness on their prostate, we end up becoming a little bit more concerned that they may have cancer, and that may lead us down a different path. And so it's really important that at least on your first visit, you have an examination of the prostate to see what it feels like. We oftentimes do bladder scans. These are quick ultrasound tests that we do by placing a probe on the patient's abdomen, sort of over the bladder area, and we measure how efficiently the bladder is able to drain. And so we measure what we call the residual urine. So you're going to hear us talking about, the terminology is, your post-void residual, your PVR, we call that, is a certain amount of number. Now, PVRs, normally should be 0. You should be able to empty your bladder all the way. But of course, most men, as we get a little bit older, we don't empty our bladders completely, and that's okay, but it's important for us to understand the trend, is it getting worse, is it getting better, and also to make sure that the number is not terribly high. We do a symptom score. You fill out a questionnaire, and the final question on that questionnaire is, how much of a bother is this to you? And I think that question is probably the most important question in all of the IPSS questionnaire. And we're going to look at those questions in a minute. Now, you may also have some other studies. You may have something called a UroFlow test, where you urinate inside the special toilet, sometimes with a little pressure cuff around the penis that measures the pressures and the flow of urine, and that gives us some objective information about how your bladder is doing. Oftentimes, we do an ultrasound of the prostate. Now, the ultrasound can be done through the rectum. It's an ultrasound probe that we place inside the rectum to measure the size of the prostate. But also, we can do that through the abdomen and measure the size of the prostate. And that's important because the size of the prostate determines what the options are in terms of medications or procedures that we may do to help you with your urination. And lastly, we do cystoscopies, look in the bladder. It is really important for us to look inside your bladder, because oftentimes we find other diseases such as bladder stones, bladder cancers or tumors, scarring inside the urethra. And it is very common that we see people who are treated for months and years for a presumed diagnosis of BPH. They're not getting better. We finally look in the bladder and we identify that the problem actually is something else. And so for a urologist to look in your bladder is like a cardiologist listening to your heart. And so it's really important for us to be able to do that. It's an office-based procedure, sometimes done in the office, sometimes done in a surgery center. And overall, it's a very well-tolerated procedure, so it's not a huge deal to do. The International Prostate Symptom Score, that's the questionnaire that you fill out. It's a number of questions that assesses your ability to urinate, frequency, intermittency, urgency, weak stream, straining, getting up at night to pee, and then lastly asks you about your quality of life. And then based on those questions, you basically are placed in a mild, moderate, or severe category. And our guidelines tell us that somebody who's got mild symptoms may be observed. If you have moderate symptoms, you should definitely consider some kind of a treatment. And if you fall in the severe category, you definitely should have treatment for this condition. But most importantly, what is the quality of life? And if your quality of life is poor and your symptoms are relatively mild, then we have to try to get to the bottom of why the quality of life is poor and what we can do to try to make that better. So far we've talked about what BPH is, what happens, and why people develop urinary difficulties. Let's now talk about some treatment options and what we can do about it. Now, there's a whole continuum of treatments available. And if you look at this chart, going from the left side of the chart to the right side of the chart, you have increasingly more invasive therapies. And so watchful waiting is one. If you're in the mild symptom category, we can just follow your symptoms and make sure that you're doing okay. We can start you on medications or maybe have you take some herbal medications. Ultimately, we can go to doing a TURP or a surgery where we trim out the inside of the prostate, and we'll talk about that in a minute. And now, of course, there are less invasive options available like the UroLift, which oftentimes are office-based procedures, which give you effect that is almost as good as doing a surgery and certainly better than medications without having to take medications. And so this UroLift really fits nicely in this continuum of least invasive to most invasive. We also do heat-based therapies where we heat the prostate, and that can be done in the office as well. And there's pros and cons with that procedure. And so we'll go through these one by one. As far as watchful waiting is concerned, that's the least invasive option, and it certainly is a reasonable option for somebody who is not badly bothered by their symptoms. There's no surgery, there's no medications, there's no side effects really. However, we have to monitor you carefully. There's going to be some lifestyle changes. Symptoms may persist and may get worse, and also the function of the bladder can get worse. And every once in a while, we see a patient who comes in with really mild symptoms, but they have a blown out bladder. And so what ends up happening is they have mild symptoms, they're not getting the attention they need, and over time, the bladder muscle sustains damage and stops working. And so lack of symptoms doesn't necessarily mean that you're in great shape. And so even people with mild to moderate symptoms need to be followed carefully to make sure that we are not watching the bladder deteriorate under our eyes. If you have symptoms that are more bothersome, we certainly can start you on medications or herbal remedies. God knows if you do any Google search about BPH or urinary symptoms, your Facebook page is going to be flooded with advertisement for all sorts of herbal remedies. And there is some science behind it. There are herbal remedies, there are plant-based remedies that have estrogenic effect, basically. And so what they do is they can help to relax or shrink the prostate a little bit. Saw palmetto is one of them, and there's a lot of others, beta sterols and other compounds. The trouble is that there's really no good studies that looks at herbals, and there's very poor quality control. And so there's no standards of production necessarily to make sure that you're getting what you're paying for. And so when patients ask me, they come in with bottles of herbals that they just bought from some 800 number, they ask me, well, is this good for me? I say, maybe it could be good for you. It certainly is good for the person who sold them to you, but let's look into it and let's see if it actually is doing anything. And so don't assume that by taking herbals, you are somehow helping your prostate in the long run. A lot of people spend a lot of money, upwards of $100 or $200 a month, buying these supplements, and their thought process is that maybe they are helping their prostate stay healthy, and they're avoiding problems down the line. That's not the case. If you have urinary difficulties, certainly you can consider herbal remedies. An alternative to herbal remedies, and certainly something that's better studied and more proven, is to take medications. You've heard these terms: Flomax, Tamsulosin, Avodart, daily Cialis. These are all medications that help to relax or shrink the prostate. And in doing so, they can give you relief. Medications really, for the most part, are quite effective and they do a good job. Problem with medications are that once you start on it, you have to stay on it. This is not like an antibiotic that you take and then you can stop taking it after 10 days and your symptoms are better. This is a medicine that once you start, you have to take for the rest of your life. And of course, these are medications, these medications are chemicals, and there's the whole concept of polypharmacy that we don't really appreciate. So what happens is when medications are studied in patients and they're approved by the FDA, it's basically that compound that's studied and it's deemed to be safe in a person. We don't know when we mix all these medications with other medicines, blood pressure medicines, Parkinson's medicines, and all these other medicines that people take. Now you have chemicals that are placed on top of chemicals, and what is the combination of these chemicals going to do to your health? Nobody really knows that. And so there's some concern that people who are on prostate medicines long-term may be at risk of developing other conditions. These are mostly observational studies, meaning somebody just saw an association. Nobody's really proven that connection. And so, but it's important for you to sort of understand that, and also understand that you don't have to necessarily be on a medicine because there are alternatives available. The main side effect of these medications is that they tend to have potential side effects: lower sexual drive, erectile issues, ejaculation problems, where people develop dry ejaculation. They can still have an orgasm, but just no emission, nothing comes out. People can get dizzy, have lack of energy, and certainly as people get older, we don't need to make them more dizzy or have them less energy. And so medications we use very commonly, but I, at least in my practice, am very cautious and careful about over-medicating people. And I see it as my job to try to move people past medications if there is an option available. So one of those options is the UroLift procedure. Now, UroLift has been around for a number of years. This is not a new procedure. The idea is that we place small implants within the prostate to prop the channel open. People call it sometimes a stent, but it really is not a stent, because a stent is a continuous structure that keeps like an artery open when it's placed inside the heart. A UroLift, and you'll see a picture of it in a minute, these are small implants that we place inside the prostate, and they simply lift the prostate tissue away from the urethra, thereby creating a more open channel so urine can flow more easily. This is a procedure that can be done in the office. Sometimes we do it at a surgery center, but most times we do it in the office. And it uniquely preserves sexual function. So of all the options that we have available, UroLift is the one that has zero sexual side effects, as best as we know and as best as we have studied. And so that's really quite clever, and it's a very important thing for us to keep in mind. One of the main advantages is that after the procedure, you have relatively rapid relief of symptoms. The first 7 to 10 days, there will be some frequency and urgency and some issues with urination. But after about 7 to 10 days, people return to their normal urination and start to see an improvement in their urinary system. And usually within about 2 to 4 weeks, we can stop medications. And then there's been plenty of studies that shows that UroLift tends to have pretty good durability. Any treatment for prostate cancer is durability, meaning the prostate continues to grow, and so the effects of that treatment may wear off, and medications wear off and stop working. Even the most invasive option we have available with resecting or removing part of the prostate, still about 5 to 8% of people have to have another treatment within 5 years. With minimally invasive treatments like UroLift and heat-based therapies that we'll talk about in a minute, there's always been concerns that even though they work well initially, they may not work long-term. And so when UroLift first came out, they did studies and they followed this. They followed our patients for 5 years plus, and they saw that the effects that the patients saw initially were quite durable. And something like 10 or 15% of people had to have another treatment, like a medication or another UroLift or something else, within those 5 years. But the vast majority of people who had an effect had sustained effects even 5 years out. And so that's one of the unique advantages of this minimally invasive procedure. After the procedure, of course, there's going to be some discomfort. We're going through the urethra. We're placing these little implants inside. So you're going to feel the procedure itself a little bit. Afterwards, you're going to have some blood in the urine for about 7 to 10 days. There's going to be some urgency and frequency of urination while things are healing on the inside. But really, most of these symptoms resolve within about 1 to 2 weeks after the procedure. The alternative is some kind of a heat-based therapy. So the idea is that if you heat the prostate, the tissue will shrink. And as it shrinks away from the urethra, from the P channel. And so by shrinking it, you can open the channel, urine can come more easily. These heat-based therapies can be done in the office, and certainly they have fewer permanent side effects than surgery. All heat-based therapies, regardless of how we deliver the heat, will have some discomfort. That's normal. You feel the heat. You're burning the prostate essentially, and so you'll feel it. But it's not terrible. It's actually pretty tolerable, and most people do just fine with it in the office. There's going to be some blood in the urine. There's going to be some urgency. This is a common theme after these procedures. The one disadvantage of the heat-based therapy as opposed to UroLift is that more people have to wear catheters afterwards, because when you heat the prostate, it tends to swell up, and as it swells, it takes usually a few days to maybe a week or two for the swelling to go down, and so during that time, you may have to wear a catheter. And also, because we're relying on the heat to eventually shrink the prostate, symptom relief is realized a little bit less quickly, and so it takes usually 4 to 6 weeks to see symptom relief, whereas with UroLift it happens over 1 or 2 weeks usually. And of course, there's always potential for sexual side effects. Now, the potential is relatively small with these heat-based therapies, but we are destroying prostate tissue, and so there's potential for sexual side effects just like any other destructive therapy. And then lastly, we can go in and trim out the prostate. These are outpatient surgeries. We look through the urethra, so there's no cutting involved on the outside. We look through the urethra, we go into the bladder, we find the prostate, and we trim out the inside of the prostate. Now, there's a lot of different ways we can do that. We can use laser energy to melt the prostate tissue and open the channel. We can use an electric loop to cut the prostate tissue. Regardless, we're removing tissue, we're making the channel bigger, and then we place a catheter that stays in for about 3 to 7 days to allow the inside to heal up. Most people go home. Most people have blood in the urine for a number of days to weeks after the procedure, and most people usually are back to normal activity within a few weeks after the procedure. There is an incidence of developing erectile dysfunction after prostate surgery, so we have to be careful about that. About 10% of people develop new onset erectile dysfunction. About half to 80% of people lose ejaculation. So when they have an orgasm, no fluid comes out. 3%, so 3 out of 100 people can develop some leakage of urine. And about 7 out of 100 people can develop some scarring. And so this is not a completely benign procedure, but it is a good procedure, and it's considered the gold standard. So whenever you hear gold standard terminology in medicine, it means it's the procedure that's been done the most, it's been done the longest, it has the best track record long term, and all other procedures try to compare themselves to this gold standard. So there's still, surgery for the prostate is still the gold standard, but given the potential side effects and the invasiveness, we're always in search of less invasive options. So the UroLift system, and I'm going to talk about that for a few minutes, is clever. So the way it works is, and over here you see the bladder, the urethra going through the prostate with some obstructive prostate tissue. And the way the procedure works is we look inside with a scope. So this is a scope going in. We open up this channel. We push on the prostate, which then squeezes the prostate and opens that channel. And then we place these little implants inside. The implant places an anchor on the outside of the prostate. There's a suture that goes through the prostate. It places an anchor on the inside of the prostate, and it squeezes the prostate tissue between these two anchors. And we place anywhere from 4 to 6 or 7 implants, and in doing so, we open the channel. So when the bladder tries to drain, it has less resistance and it can drain more efficiently. This is what those implants look like. This is a dime, and so in comparison to the size of the dime, it's about half the size of a dime. This is the part that goes against the capsule of the prostate on the outside. This is a suture that goes through the prostate, and this is the tap that goes on the inside of the prostate, and it squeezes the prostate tissue between these two implants. So that's what it looks like. So if this is the cystoscopic view of an obstructive prostate, these are the lobes falling in. We place those implants, and it props the channel open, and so you can look inside the bladder. That's the bladder on the deep side of the scope. And so if you open the channel like this, urine is going to flow out much more easily. And so that's the idea behind the UroLift system. After the treatment, you'll have symptom improvement within about a couple of weeks, but you can have sustained and continued improvement for up to 3 months after the procedure as the swelling of the prostate goes down and other issues. Most common side effects of the procedure are mild, and they include a little bit of pain, some burning with urination, blood in the urine, some pain or discomfort in the pelvis, urgency of urination, and this usually resolves within that first couple of weeks after the procedure. Most times these symptoms are pretty mild and people are pretty happy when they do the procedure. And then, as I spoke previously, it's durable over 5 years. It is recognized, it's reimbursed by Medicare nationally. Most Medicare Advantage plans and non-Medicare plans provide coverage for the UroLift system. And certainly if you're interested, our office will work with you and try to make sure that you qualify. And of course, our job as urologists is to first make sure that we understand what the problem is, and then to try to devise a treatment that is right for your prostate. So we have a lot of tricks in our bag, and certainly we can go from, once we establish that your urinary difficulties are from BPH, we can go from observation to medications to UroLift to heat-based therapies and all the way to doing a surgery. And certainly our goal is to improve your quality of life. It's to preserve the function of your bladder and to minimize complications like infections and other issues. And we can do that usually very successfully. We're available for consultations, and they can sort of go over that with you. And certainly if you have any questions, call us, come in to see us within Colorado Urology. We have excellent doctors who can take great care of you.
Before we start the question and answer, I do want to let you know that you're more than welcome to go to www.coloradourology.com. It's coloradouro.com, and you'll see all the information about our Denver-based clinics, including bios on Dr. Saram and his partners. You can also, if you're interested in calling the office to get a consult for any of the treatments that Dr. Saram mentioned, or if you have questions and even want to do a telehealth video conference, feel free to call our office at 303-695-6106. And I'll repeat that again. I do have a couple questions, Dr. Saram. I'll start out with one. If I have an enlarged prostate and also a few kidney stones, will the enlarged prostate make it more difficult to pass those kidney stones down through the urethra to the bladder?
So that's a good question. So if you think about the anatomy, the kidneys produce urine. Urine goes down these tubes called ureters. The ureters join the bladder and dump urine into the bladder. The bladder holds the urine and then pushes the urine out through the urethra. And so if you have an enlarged prostate, a stone may get hung up in the bladder once it passes into the bladder. But an enlarged prostate will not prevent you from being able to pass a stone into the bladder. Of course, if the stone is passable, some stones are large and they're not passable, and that's a whole different question. But an enlarged prostate can sometimes cause the stones to get hung up in the bladder once they go into the bladder. And interestingly, they tend to grow inside the bladder. And so sometimes people with BPH or urinary difficulties, if they're not emptying their bladder efficiently, they grow bladder stones, which can be quite uncomfortable and have a lot of issues associated with it.
If you're taking finasteride now, can you switch to UroLift and restore sexual dysfunction caused by finasteride?
So the answer is yes, with an asterisk, and hopefully yes. And so the way finasteride works is it changes hormones inside the body. It changes the conversion of testosterone to this other hormone called dihydrotestosterone. And it's actually dihydrotestosterone that contributes to a lot of our function, from a sexual standpoint and prostate and everything else. And so by having less dihydrotestosterone, you can have problems with sexual function. If you stop taking finasteride, the idea is that your dihydrotestosterone levels should normalize, and whatever process that had happened previously should reverse itself. The trouble is that erectile dysfunction also happens, sexual dysfunction also happens with aging, and so sometimes it's a little bit hard to determine whether the sexual dysfunction is an aging problem related to cardiovascular and other issues, or if it's for sure related to the medication. The only way to do it is to stop taking the medicine, and the only way to safely stop taking the medicine is to do some kind of a procedure like UroLift to hopefully get you off the medication.
I had a UroLift and 3 clips were put in. It's been almost 3 years now, and I'm starting to develop some symptoms. Might it be that I need more clips?
So yes, 3 implants is a little bit low in terms of the number of implants. I'm sure you had a pretty small prostate, and that's what they thought you needed at that point. We always want to place the number of implants that we think are needed at that given time, and we reserve the option to go back and place more implants if the prostate grows or if the anatomy changes with time. So yes, you do have the option of doing another UroLift procedure. You're going to have your bladder looked at, your prostate looked at, and we have to do some tests to make sure that there is no other reason why your symptoms are coming back. But if we determine that it's because of the prostate, yes, you can have more implants placed.
Dr. Saram, what types of things can raise your PSA?
PSA is produced by the prostate. So anything that irritates the prostate can cause a temporary rise in the PSA. So an infection, an irritation of the prostate can cause a temporary rise in the PSA. Recent sexual activity can sometimes do that. Not in all, but in some men. We always say if you're going to have a PSA test, try to abstain from any sexual activity for 24 to 48 hours prior to try to make sure that there's no erroneous reads on the PSA. An enlarged prostate makes more PSA. So BPH tends to make more PSA. Of course, prostate cancer makes more PSA. So PSA, even though it's not a very specific test, it really is a pretty excellent test to try to start the conversation to see if somebody needs further testing and see if they potentially have prostate cancer. But we fully recognize that there's a lot of other reasons why PSAs may go up.
Dr. Saram, what symptoms would a patient expect to see if their bladder is starting to be overworked and the muscle is thickening?
It's all the symptoms that we described. So if the bladder is being overworked and the muscle is thickening, you tend to develop frequency and urgency of urination, a sudden urge to urinate, and sometimes even a little bit of dribbling if you can't hold the urine back. You'll definitely notice a drop in the flow of urine, and in severe cases, people can develop incontinence or dribbling of urine because their bladder is so full that it just sort of overflows and it passively drains that way. The concerning part, and this doesn't happen frequently, so I'm not trying to scare people, but what we see, and is very concerning sometimes to us, is people who come in with relatively mild symptoms, and then we measure with an ultrasound their PVR, the post-void residual that we had talked about previously, and they have 1,000 cc's or 2,000 cc's in their bladder, basically having a basketball in their belly, and we put a catheter in the bladder and drain, and they suddenly have, that they're thinner by 2 pant sizes. And so this happens probably few times a year in my practice where somebody comes in thinking there's nothing wrong, and we identify that their bladder is essentially shot. It doesn't work, and it stopped giving them signals that they're in trouble. And so that's my job as a urologist, as long as people follow up with us, is to make sure that their bladder is in good shape and it's not sustaining damage silently.
And how often should one have a PSA test done, Dr. Saram?
So the PSA, there are some pretty clear but also somewhat controversial guidelines on PSA screening. Now, remember, you're getting the PSA screen because we're trying to screen you for prostate cancer. And there's a whole lot of conversation about appropriateness of PSA screening, age and health of the patient, because generally speaking, prostate cancer, and we're deviating a little bit from the topic, but generally speaking, prostate cancer is a pretty slow-growing disease. And so if you're 85 years old, and at that point, it probably doesn't make sense to do really aggressive prostate cancer screening. But if you're younger and you're healthy and you have a long ways to go, it certainly makes sense to screen for prostate cancer with a PSA. PSA should be done annually, probably around the age of 50 or starting the age of 50 until maybe early 70s, thereabouts. If there's a strong family history of prostate cancer, the first PSA probably should be done a little bit earlier, maybe in the mid to late 40s, rather than waiting until you're 50 years old. And then you have to discuss that with your doctor and understand what makes sense in terms of frequency. Do you do it once a year? Do you do it every other year? But it's important to do the PSA test.
The next question is, I had a TERP and a green light, still have 3 or 4 low flow urinations each night. Can I have a UroLift?
Yes, you need a series of tests to figure out what the problem really is. Is it that you still have obstructive tissue? Sometimes with TURPs, especially with laser TURPs, we tend to not remove as much tissue. And so sometimes we look inside and there's still a lot of obstructive tissue. And we can do a UroLift. Those people actually do very well because some of the prostate's already been trimmed, and we're sort of just perfecting the opening using the UroLift system. So yes, you should have testing, and you are potentially a candidate for UroLift.
And another question on UroLift, what's the percentage of incontinence, and what is the percentage that need a catheter?
Percentage of people developing incontinence after a UroLift is 0. That just should not happen. We're not removing tissue, we're not heating tissue, we're not damaging tissue in terms of the sphincter muscle or anything else. And so really there should be no incontinence. Rarely people develop some urgency or frequency of urination, and sometimes they don't make it to bathroom fast enough, so they have a little bit of dribbling, but that usually gets better within the first few weeks after the procedure. Obviously, permanent catheter is not at all an option. I mean, we're not doing this procedure to render you catheter dependent, and so sometimes after the procedure we choose to place a catheter. There's nothing wrong with placing a catheter overnight. I just did a procedure today, and I chose to place a catheter in somebody because their bladder was a little bit bloody, the urine was a little bit bloody, and it was a fairly involved procedure, so there's sometimes swelling with it. So we put a catheter in overnight, take it out the next day. Chances of needing a catheter longer than a couple of days after the procedure is really quite small. Probably less than 1 or 2% of people have catheters that are long-term. And certainly, if you end up with a catheter that's long-term, that means there's something wrong with the way the prostate responded. And so we look inside, we identify the anatomy. We always have the option of doing more UroLifts. We always have the option of doing a TURP where we go and trim out the prostate. So by doing a UroLift, you're not eliminating other options by any means.
Dr. Saran, can a UroLift be done on a prostate that has had radiation treatment for prostate cancer?
That's a great question, and the answer is yes. If you're planning on having radiation for prostate cancer, the best time to address urinary difficulties is before the radiation starts. I mean, that kind of makes sense because you don't want to irradiate a prostate and then afterwards try to do things to it. However, if you've already had radiation and you have urinary difficulties, we can do a UroLift procedure, and that probably is the only and the best procedure available in that situation. A radiated prostate doesn't heal as well, and so if you do heat-based therapies or if you go in and trim out the inside of the prostate, you may have trouble with healing, because radiated tissue doesn't want to heal. And so by placing these implants, we can usually open the prostate up enough without doing any damage to cause problems with healing. And so yes, the answer is yes, and those are some of the happiest patients because it works quite well.
What PSA levels are considered okay versus how high is a concern or dangerous? And is there anything that one can do to lower their PSA?
When PSA testing first became available back in the 1980s, we used a cutoff point of 4 and said anything below 4 is good, anything above 4 is bad. Through experience and many, many, many years of doing PSA screening, we have identified that the absolute value of the PSA really doesn't mean a lot. It's very much age dependent. So if you're 40 years old and you have a PSA of 2, that's too high. If you're 65 or 70 years old and you have a PSA of 3 or 4, that's perfectly acceptable. So depending on the age and the size of the prostate, you're allowed to have different levels of PSA. But most importantly, we look at the rate of change in the PSA. We know that the PSA can rise slowly as we get older, but if the PSA changes quickly over a shorter period of time, that usually is a cause for concern. And so if you're 55 years old and your PSA goes from 1 to 3, that's concerning. That's a real change, and we need to look into it. If you're 55 years old and you've had a PSA of 3 for 5 years, we don't worry about it because it's a stable PSA. So there's no one-size-fits-all when it comes to PSA screening. We have to use a fair amount of information to try to figure out how to interpret it properly.
And Dr. Saram, is there anything that you can do to lower your PSA?
Yes, there are medications that lower the PSA, like finasteride. That finasteride is a medication that we use to treat BPH, and that falsely lowers the PSA by half. And so if you're on finasteride and you have a PSA test, you have to always double that number, and that's your true PSA. So that's really important. A lot of people forget about that. And by the fact that you're lowering the PSA doesn't necessarily mean you're changing prostate cancer behavior in that situation. There are supplements, plant-based supplements that tend to lower the PSA a little bit because a lot of them have estrogenic effects, and if in presence of estrogen, the prostate makes less PSA. The trouble is that makes it very difficult for us to be able to interpret the PSA when we're trying to identify men who may be at risk of prostate cancer. So lowering the PSA doesn't necessarily change the risk of prostate cancer. It's just lowering a number, and then it makes it a little hard for us to try to interpret what's happening. Now, the other question is, are there things you can do to lower the risk of developing prostate cancer? And again, that's a whole hour-long conversation otherwise. But in general, there's genetic factors. You can't do anything about that. There are environmental factors. There are dietary factors. And so we say that diets that are good for the heart tend to be good for the prostate. Mediterranean-type diets tend to be good for the prostate and risk of prostate cancer. And diets that are high in lycopenes. Lycopenes are found in fresh tomatoes and watermelon tend to be pretty good for the prostate. But besides that, I wouldn't go too crazy buying expensive supplements to try to lower your PSA. You're not really changing anything other than changing a number.
Another question, when I feel I have to pee but seems to just fall out via gravity, I don't have the option to push. If I try to push, the flow stops.
Mm-hmm. That's a very, very classic symptom of BPH. So what's happening is your prostate is collapsing around the urethra. So if you push, the prostate collapses further around the urethra and cuts off the stream. So instead, you've learned to let gravity do its work. So you're just standing there and relaxing your sphincter muscle and then allowing urine to sort of, get pulled out through gravity. That's not a great way to urinate. Certainly takes a long time. It's frustrating. You don't empty your bladder properly. You have to probably go frequently and multiple times. It's time to have your prostate checked out.
Why does the prostate grow with age? Is it a function of testosterone production?
So that's actually a good question. I'm not sure if anybody knows that. We know that men who have no testosterone don't grow their prostate. So if somebody is castrated or if they have a genetic condition where they don't make testosterone, they tend to not have an enlargement of the prostate. So testosterone certainly has something to do with it. And the assumption is that as we get older, the prostate has been exposed to testosterone for longer periods of time, and it tends to enlarge. But there's a lot of other factors. For example, the prostate is made up of not just glands that enlarge as we get older, it also has a lot of muscle in it, smooth muscle. And this muscle tends to get tighter as we get older. It's not necessarily the size of the prostate, it's the tightness of the prostate because the muscle tends to get tighter. And we think that the reason that muscle is getting tighter is because there is what we call an upregulation or more of the receptors that live on that muscle that respond to hormones going around the body. And so there's a lot of different factors why we tend to develop urinary difficulties as we get older. Some of it is enlargement of the prostate, and that is sometimes related to exposure to testosterone. Of course, genetics also plays a pretty big factor.
Is it possible to remove one lobe of the enlarged prostate surgically to make it smaller and function with the other lobe?
No, I mean, technically it's possible to do that, but it often doesn't work because what ends up happening is you trim out surgically one side of the prostate, and then the other side of the prostate just kind of falls in and fills that space and makes it hard for urine to pass through. So creating an asymmetric channel, a channel that is not straight and is asymmetric, usually creates kind of an S-shaped curve or S-shaped path out of the bladder, which is even more obstructive. So we don't do that. And there's no reason to do it. Once you go the surgical route, you kind of got to go the full way.
Can patients with type 2 diabetes who need to urinate frequently develop bladder damage due to overuse?
So there's a lot of different reasons why people with diabetes have urinary difficulties. Oftentimes it's the prostate. So we should not assume that urinary difficulties in a diabetic patient are necessarily the diabetes. It could be the prostate, and if we fix it, your urination may get better. But people with diabetes also tend to have frequency of urination because of the sugar that's excreted in the urine, and it tends to be irritating and it tends to cause more troubles with urination. And then lastly, people with diabetes also can have some nerve dysfunction. When there's nerve dysfunction, the bladder and the prostate may not work properly. So the damage that you may sustain from your urination, is maybe because of nerve dysfunction from a poorly controlled diabetes condition, or it could be from the bladder not draining properly from prostate condition. So there's a lot of reasons why that could happen, but certainly don't just assume diabetes is the underlying cause of your urinary difficulties.
Is UroLift an inpatient procedure, and how long does that procedure take?
No, so UroLift is outpatient regardless of where it's done. It can be done in the office, and certainly you're in the office for about an hour, hour and a half. The procedure itself takes only about 5 to 10 minutes at most. And so you're in the office a little bit before the procedure to get ready for it, and then you're in the office afterwards to make sure you recover, you're able to urinate, or if you have a catheter, you know how to use it, and then you go home. It can also be done at a surgery center, an ambulatory surgery center, and it's an outpatient surgery. You undergo an anesthetic, so an anesthesiologist is present, they give you a quick anesthetic, and then we're in and out within 5 or 10 minutes, and then, with the recovery, and then you go home. So either way, it should be an outpatient procedure, either done in the office or at the surgery center under a anesthetic.
You mentioned earlier the diets that would help. This specific question is a plant-based diet, will a plant-based diet change or lower your PSA?
Potentially, yes. I'm not an expert in nutrition, so I'm not going to claim any significant expertise, but we know that plant-based nutritions, for example, some plant-based meals that have high beta-sterols, phytosterols, these are steroids that have estrogenic effect, can lower the PSA. There's a urologist named Mark Moyad. If anybody's interested, he has a book on nutrition and prostate. He is really very knowledgeable and he gives a great talk. I don't know if he has any YouTube videos or anything you can listen to. Is Mark Moyad, M-O-Y-A-D. Very, very knowledgeable, good guy. And his book is actually very informative.
If I have urinary difficulties, does it mean that I have prostate cancer?
No. So that's sometimes that's the fear that brings men into our offices, and it's a good thing that it brings men into our offices because we can test you for both conditions. We can test you to make sure you don't have prostate cancer, and then we can also test your urinary difficulties and make sure that you're not in trouble with your urination. But urinary difficulties by no means are associated with prostate cancer. Now, if you have really bad prostate cancer, you could potentially have urinary difficulties. You can have really mild prostate cancer and have urinary difficulties independent of the prostate cancer. And so that's why we test you for both usually when you come to see us.
I'm taking, oh my goodness, here we go. My clinical expertise is going out the window. Tamoxifen and finasteride.
Yes.
Is that acceptable?
Yes. So tamsulosin relaxes those muscle cells that we talked about within the prostate. So it tends to relax the prostate and help urine come out more easily. Finasteride over time can shrink the prostate by changing the hormonal situation within the prostate. And so a combination of both treatments is a pretty common way that we treat prostate conditions. The question I have for you is, you asked me if it's acceptable, and of course from a medical standpoint it is acceptable. My question back to you is it acceptable to you as a patient to take 2 medications for the rest of your life when there could potentially be procedures available to help you? And I'm not trying to push a procedure at all. It's just those are the questions that you have to ask yourself. Do I want to look into this further and potentially stop one or both medications? Or are you happy taking 2 medicines, in which case it's perfectly fine as long as you're being monitored long-term to make sure there's no sustained bladder damage or other problems. I really appreciate all the people who are on this call. We had upwards of 50 or more people attending, which is just wonderful. This is a passion. We do a good job with this. Colorado Urology, we have offices all over, up and down Front Range. We have excellent doctors who can see you, and I really encourage you to go to our website, coloradouro.com. There's lots of good information about prostate and other urologic issues, and we're very accessible for you to come and see us.
The phone number is 303-695-6106. Again, that phone number is 303-695-6106. We do offer telehealth visits, so you can talk with Dr. Saram from the privacy of your home. You can also schedule a consult as well in the clinic. As you know, with all other businesses and with COVID, we do have a little bit of a wait time, but depending on the severity of your needs, we will certainly find a spot on Dr. Saram or one of his partner schedules to see you as promptly as possible. So I hope you all have a great evening and take care of yourselves and stay safe. Thanks, Dr. Saram.
Thank you, Lenny.